Chapter 24 talks about endodontics. It starts on page 564 of your dental assisting textbook. In chapter 4, we're going to be talking about endodontics. We'll be defining endodontics and describing what an endodontist does. We'll describe pulpal and periapical disease. We'll identify the diagnostic procedures, as well as the instruments used in the endodontic procedures, as well as describe their functions. We'll talk about the materials used in endodontics and describe their functions. We'll talk about the endodontic procedures, excuse me, and the responsibilities of the dental assistant. We'll describe the entire endodontic retreatment and explain surgical endodontic procedures and the instruments used. So first, let's start off by defining endodontics. Endodontics is a branch of dentistry that deals with the diagnosis and treatment of diseases of pulp and periapical tissues. Endodontic procedures include the diagnosis, root canals, and periapical surgeries. Vital pulp is a healthy pulp that has never had a root canal. They may be inflamed, but they are capable of healing after the irritant is removed. With a non-vital pulp, the tooth no longer responds to stimuli. The tooth is considered necrotic as it is unable to heal. With reversible pulpitis, okay, there's those two types. There's irreversible and then there's reversible pulpitis. And pulpitis is just the irritation or the inflammation of the pulp. And with reversible pulpitis, the inflamed pulp is able to heal when the irritant is removed. The causes of this disease are incipient caries, enamel fractures, and occlusal attrition or malocclusion, like a bad bite. The symptoms of reversible pulpitis are sensitivities to hot and cold. Treatment includes the removal of the irritant and placement of a sedative dressing to heal the pulp. Irreversible pulpitis is caused by advanced dental decay, impact trauma, fractures, invasive restorative procedures, and adverse reactions to dental material. Inflammation continues until the pulp tissue cannot recover. Irreversible pulpitis results from prolonged inflammation where the pulp tissue is unable to heal. Some symptoms include dull and continual pain or short and sharp pain that usually occurs with this irreversible pulpitis. And treatment usually involves root canal therapy or extraction. Pulpal necrosis involves the death of pulpal cells once exudate, which is pus and gas, form in the pulp chamber. The process is slowed if pressure is released through a fistula or caries. When an infection in the pulp reaches the apex of the tooth, it continues into the periapical area, which is this little gray, we call these little gray shadows at the apex of the tooth. We call them radiolucencies, which are just little dark shadows. And this is indicating apical periodontitis. And it's actually a periapical abscess. So all of this shadowing here is when the infection kind of eats away at the bone. We call this osteomyelitis. And this dark shadow is actually the bone density has decreased since the bacteria has eaten away at the bone. And it's actually usually area of blood and pus that is forms in its place. Apical periodontitis is a periapical disease in which pulpal inflammation extends into the periapical tissues. If left untreated, a cyst filled with liquid and semi-solid material forms. With periapical abscesses, the localized destruction of tissue and accumulation of exudate results. A release of pressure can relieve the symptoms. So oftentimes a dentist may choose to do an incision right at the tip of the the gum tissue right where the tip of the tooth would normally be. And we will release a lot of that blood and pus that's causing that tissue, which is causing that, excuse me, all that blood and pus, which is causing the tissue to be inflamed and causing the pain. Endodontic diagnosis includes medical and dental history, clinical examination, and review of communication from the referring dentist's notes. The first step is asking the patient to complete a medical history. The medical history is reviewed and clarified to ensure accuracy. Medical conditions and medications are reviewed here as well. The dental history is reviewed to provide the dentist with the review of past dental experiences. Subjective is the problem in the patient's own words, such as the type of pain they are experiencing, whether it's constant aching or sudden throbbing, whether it's sensitive to hot and cold, and the length of the pain or duration of the pain that they experience. So those were subjective concerns or the subjective examination. In the clinical examination, an objective examination is performed to search for extraoral tissues, facial asymmetry, swelling, redness, and fistulas. In the intraoral clinical examination, tissues are evaluated and palpated in the intraoral clinical examination to find caries, discoloration, and fractures. Clinical testing procedures include radiographs and radiolucent areas on the x-ray indicates bone involvement. Palpation is when the dentist will feel around the areas or put pressure around the areas where the tip of the tooth would normally be. And if there is pain to that type of palpation stimulation, that can note some type of irreversible pulpitis. Percussion is done when the dentist lightly taps on several teeth in the area, including the tooth that is in question of possibly being infected. And that is just a process of elimination for identifying which tooth is actually hurting the patient. Mobility is evaluated to determine the condition and involvement of the supporting structures of the tooth. Teeth that move 2 to 3 millimeters should not have a root canal therapy as they lack sufficient support. Okay, and an extraction would normally be done instead. Pressure is applied on the lingual and facial sides of the tooth to see if they move at all. Cold testing is accomplished using dry ice, a solution called ethyl chloride, or ice, just regular ice, to determine sensitivity. A normal tooth will respond within a few seconds. Intense and long-lasting pain reveals irreversible pulpitis, and no response means that necrotic pulps are present and the tooth has already died. A heat test is accomplished using heated gutta percha, which is applied to the tooth. And if the tooth responds to pain or if pain increases and lasts, this also indicates irreversible pulpitis. So here is just a couple of pictures of this doctor using what looks like to be dry ice on the tooth. And there is a plugger with a little tip of melted gutta percha, which is obviously hot enough that should create a heat response to the tooth in question. There is a high instrument that has high frequency currents that create an electrical stimulus to the tooth to determine if a tooth is vital or non-vital. The control tooth is a tooth in the opposite arch, and electronic pulp testers may give a false reading. Therefore, a pulp testing must be done in conjunction with other testing to get a more accurate result. Fiber optic light shines through the crown of the tooth in transillumination testing. Shadows would indicate vertical fractures, and in that case, the tooth may need to be extracted. Selective anesthesia is used if the patient cannot identify the tooth or arch that is causing the problem. Here, the suspected tooth is numbed and anesthesia is injected into a selected area. If pain ceases, the problem tooth is detected. It helps determine which tooth is problematic by the process of elimination. In order to determine the status of the pulp, whether reversible pulpitis or irreversible pulpitis exists, a removal of dental caries must be performed in some patients. So, what is an advanced stage of periapical infection that spreads into the bone? Remember, we spoke about this. This is called osteomyelitis, and that is when you look at the tip of the root and you see that we have that radiolucent area in the bone itself, indicating involvement of the bone, which is osteomyelitis. So talking about barb brooches are made of fine metal wire with the tiny sharp projections along the instrument shaft. Brooches are used to remove soft tissue from the pulpal canal. They are sized differently from extra fine all the way to coarse, and they usually have color-coded handles that indicate their size. Endodontic files are used to enlarge and smooth the canal. They are long, tapered, and twisted instruments that move up and down inside the canal and are available in various diameters and types. Standard files are known as K-type files, and headstrom files are shaped kind of like a pine tree. The flex files are made from stainless steel for optimal balance, flexibility, strength, and sharpness. The reamer is not used as often as a file, but it is also used to enlarge the canal, and it is applied with a twisting motion instead of an in and out motion like a K file or a headstrom would be. There are a variety of organizers for storage and organization of endodontic reamers and files. Some may be sterilized, and some have gauges or stops for measurement when using the instruments. Rubber stops, also known as file stops, endostops, or markers, are small circular discs that have pre-punched holes in the center. They are placed on reamers and on files to mark the length of the root canal. Gates Glidden drills are used with latch attachments on low-speed handpieces. They also have long shanked and elliptically shaped ends with blunt football shaped ends. There are 6 sizes that are marked near the notch of the shank, where you will see tiny little engraved rings that indicate the size of the Gates Glidden drill. So Gates Glidden drills are used in the upper portion of the canal to prepare the opening access by removing obstructive dentin or dentin that's just in the way of all the canals to be located. And here is an example of what they look like. Again, these are used in the upper portion of the canal. And we call that the cervical third portion of the canal. And that is where we have that big area of pulp chamber. And sometimes there is an dentin or pieces of tooth structure that obstruct the opening to the canals. And this is the instrument that the endodontist might use to remove that obstruction. Piso reamers have parallel cutting edges. They almost look like Gates Glidden drills, except the cutting end is significantly longer. They are used with latch attachments on slow speed handpieces to prepare the canal for a post and to reduce the curvature of the canal orifice for a straight line access. Lentulo spirals are long, twisted, and very flexible wire instruments used to spin root canal sealer or cement into the canal. The endodontic spoon excavator has a long shank that allows the instrument to reach into the coronal portions of the tooth. It removes deep caries, pulpal tissues, and temporary cement. The endodontic explorer is designed to help locate canal orifices. It is a double-ended instrument with long tapered ends that have very sharp points. Endodontic spreaders are similar to pluggers, but these have a pointed tip. They condense gutta percha into the sides of the canal, or we also call this lateral condensation. An endodontic plugger looks very much like a spreader, except it has the flat end, and it is used to condense gutta percha. Excuse me. It is used to condense gutta percha vertically. The Glick number 1 instrument is used to remove excess gutta percha from the coronal portion of the canal and to condense the remaining gutta percha in the canal opening. Which intracanal instrument comes in diameters ranging from extra, extra, extra fine all the way to coarse? This is the barbed broach. All right, so talking about paper points, these come in various sizes from extra fine to coarse, and they are used to dry canals, place medications, and take cultures. Gutta percha is a thermoplastic material that is flexible at room temperature, yet stiff enough to be placed into the root canal. Gutta percha obturates, which is just a fancy word for filling the canal, and they are heated and placed into the canals after they're heated. Oftentimes they are condensed with spreaders and pluggers. Irrigation solutions made from sterile water or sodium hypochlorite are used to irrigate during root canals, which happen frequently to remove debris. Root canal sealers and cements are used to prevent micro leakage in the canal. They come in powders, liquids, paste, and capsules, and are typically placed either with a lentulo spiral, a K-file, or even paper points. There is newer equipment that is being introduced to assist into the endodontic procedures, and many of these have actually now have had a chance to be used in the dental field for quite some time, and are actually used quite a bit. The apex finder measures the distance to the apex of the tooth and displays the information on a digital readout. The heating unit applies heat for vitality testing, warming the gutta percha for obturation, and providing heat for bleaching procedures. The endodontic handpiece provides quarter turn motion that is consistent and even, duplicating the manual rotation during the cleaning and enlarging of the root canal. There are a variety of options available, including those with torque-controlled motors, slow speed, or those with a reduction contra angle. The vitality scanner allows the dentist to scan each tooth within minutes. It indicates endodontic problems in the early stages. The ultrasonic unit is used to apply the right amount of pressure and vibration to the tip of the tooth. The endodontic bender bends endodontic reamers, files, posts, pluggers, and spreaders. A dental microscope allows the dentist to see finer details and anatomy. And the endodontic obturation system allows filling of the root canals with more accuracy. Root canal treatment is usually completed in 2 appointments, varying with the degree of infection. So some people that have had their face basically is very swollen from a very large infection would benefit from having the procedure cut into two different appointments. Whereas somebody that is just getting a root canal because they had irreversible pulpitis for a number of reasons, but maybe they don't have an infection, those can be done in a day. So there are 10 steps in a root canal that can be divided into 2 or more appointments. Steps 1 through 8 would take place on the first visit, step 9 on the second visit, and the patient would follow up with their dentist for step 10. So on the first step is to administer the anesthetic. Second is to isolate the area, more than likely using a rubber dam. 3 is to gain access to the pulp. 4 is to locate the canals, and 5 is to remove all of the pulpal tissue. Step 6 is to enlarge and smooth the root canal once all of the pulpal tissue is gone. The root canal is then irrigated multiple times to clean out and sterilize any debris that's still in the root canal. Step 9 is to obturate and seal the root canal. And step 10 is to refer the patient to the general dentist for the final restoration. Now, I just wanted to reiterate, if this was a two-step process, after step 8, or the placement of the temporary filling, the patient would go home that day, and they would be rescheduled for step 9 and 10 for a different appointment, usually 1 to 2 weeks away. If this patient was going to get a root canal completed all in one appointment, we would simply not do step 8. After we irrigate the root canal, it would be immediately ready to obturate, and then we would refer the patient to their general dentist for the final restoration. Unless it's the general dentist that is doing the root canal themselves, then they can go ahead and start the final restoration while the patient is in the chair. So if a tooth continues to be sensitive to heat and pain and fails to heal, pre-treatment must occur, which is basically like having the root canal done, like having the root canal redone. The old gutta percha must be dug out, canals must be reshaped, re-irrigated, and re-obturated. So some of the causes for having an endodontic retreatment done is the restoration did not occur soon enough after the treatment. So the patient didn't get a crown soon enough after, and infection re-entered the tooth and caused a secondary infection. Or the restoration became loose, cracked, or broke and exposed the tooth to new decay and new infection. A pulpectomy is the removal of all pulpal tissues beginning in the coronal portion of the tooth and terminating about 1 to 3 millimeters short of the apex of the tooth in the root canal. It is the first stage of the root canal as it cleans and enlarges the canal. It is indicated for permanent teeth with deep caries or teeth with vertical fractures. A pulpotomy is when the pulp is removed from the coronal portion of the tooth, but the pulp remains in the root canal. So sometimes this is done in order to get a patient out of pain. So if they were to come into a general dentist that doesn't do root canals, that general dentist can still remove the patient's pain and refer them to an endodontist to finish the root canal by simply removing the coronal portion of the pulpal tissues. And then putting a medicated, we call it formal cresol, that basically kind of kills the rest of the pulp to deaden the pain. So pulpotomy is indicated if for primary teeth that have a pulpal exposure. Again, primary teeth are baby teeth, or if a pulp is exposed after an accident. If there is deep carious lesions, or in other words, deep decay or deep cavities that got to the pulp, or if the root does not develop completely and or the anterior tooth is fractured. So when a pulpotomy is done, the first step for the dentist after the patient is numb is to get all the decay out, and they need to actually get into the pulp chamber here. So we see here the burr that this dentist is using has completely removed all of the nerve tissue from the pulp chamber. And then a sterile cotton pellet that is wetted with formal cresol is stuck right on top of the nerve. And what that will do is basically kill all the rest of the nerve tissue so that patient is no longer in pain. After the cotton pellet with formal cresol is placed over the root canals, a zinc oxide eugenol cement is placed over that, and which basically seals everything up and acts as a temporary filling, which also just kind of adds a soothing or sedative effect to the tooth, again, to keep the patient from having any pain. Sometimes surgical endodontics is required to save a tooth. This usually involves a facial surface incision to expose the bone that is, for whatever reason, keeps getting reinfected. Um, Sometimes the root is exposed, and then some type of treatment is performed, whether it be root extraction, root tip extraction, or what we call hemisections, where we kind of completely cut the tooth in half, so that we only keep the good portion of the tooth, and then the problematic portion of the tooth is removed. So an apicoectomy is performed when extreme curvatures of the root prevents the root canal instruments from reaching the apex. The root canal is hypercalcified and obstructs the root canal therapy, or a previous endodontic treatment did not seal the canal sufficiently. So here, what the dentist would do is they would make an incision into the gum tissue that is buccal or facial of the tooth. And then they would using a surgical burr, they would gain access. They would move tissue, they would remove bone until they got to the tip of the tooth. And then they would usually amputate just the very portion where you see that dotted line there. That's where they would cut away that portion of the tooth that keeps getting infected. And they would also remove any pus formations or any infections that keep happening in this area. Okay, after that, the whole area is sutured back up, and then the patient is left to heal. And hopefully that does the trick and the patient is no longer in pain. Root amputation is a surgical procedure to remove one or more of the roots of a multi-rooted tooth due to extensive bone loss around the root. A hemisection is a surgical removal of one root and the overlying crown. So this, if we have a multi-rooted tooth, such as a molar, what they do is they basically cut the entire tooth in half, all the way from the crown, all the way through the furcation area, and the diseased portion is removed, and the healthy portion of the tooth is left intact. So what they would do is they would basically turn a molar into a premolar by cutting it in half. They would put a crown on it, and it would be treated as a premolar. These aren't done very often, and it's very rare, especially with how well implants are going. Patients would much rather pay for that tooth to be removed and a healthy implant placed in, rather than spend a whole bunch of money on a surgical procedure that may or may not work. So hemisections can be done, but they're very rare. Apexification creates a barrier over the open apex of the root of the necrotic tooth. Treatment involves cleaning out and shaping the canal and then placing material into the canal to create a barrier. Apexogenesis is a treatment of pulp of a young tooth with an open apex. Here the tooth is vital but has a carious or traumatic exposure. A calcified bridge forms over the exposed area, allowing it to stay vital, heal, and grow. So what are some reasons for root canal treatment to fail? Well, one is if we have an abscess that did not heal, a narrow or curved canal that was not found and therefore not treated, if there was new decay that grew along the filling material that was placed over the root canal, or if complicated canal anatomy went undetected, if it was too long in between treatment appointments, or there was new infection due to trauma. Okay, so this is everything I have for chapter 24. Please let me know if you have any questions. Thanks for listening.